Thank you all. Thank you all for joining us. Welcome to this IPEM webinar to mark the 10th International Medical Day of Physics, which is organised by the IOMP. So the theme for this year's celebration is Medical Physics for Sustainable Healthcare, which really is about the longevity of the profession, and we've chosen to contextualise it against climate change and sustainability, what medical physics can do to promote that, what the challenges are, and what opportunities we have to leverage. So without further ado, I'll introduce our speakers. So we've got Manraj Bull, who's here from Greener NHS, and Jerry Lowe and Ellie Holden, who are members of our environmental sustainability group. So I'll just let you introduce yourself. Manraj, would you like to go first?
Great, thanks. Thanks so much. Very excited to join you all today. So I'm Manraj, I'm a Senior Net Zero Manager with the Green NHS team, a clinician, so urologist by background. I'm working on this for the last sort of almost year and a half now. Very much focused on sort of clinical transformation with sustainability as a lens.
And Jerry?
So, hi, I'm Jerry Lowe. I'm a clinical scientist from Mount Vernon Cancer Centre. And what I tend to do is brachytherapy and bits of PET imaging, molecular imaging as well. I'm not a specialist in sustainability. It's not in my job description, apart from the extent that it's in everybody's. But a few years ago, I met with some colleagues in physics, and we just decided we wanted to try and see what we could do to be a little bit part of the solution rather than part of the problem. So that's kind of why I'm here.
And Ellie?
Hi everyone, so I'm also a clinical scientist. I'm based at Guy's and St Thomas's in radiotherapy. Again, like Jerry, I don't have sustainability in my job description anywhere, but being very interested in it from a personal view, and then also ended up working in sustainability at DHSC for a little while as well. But yeah, I think we have a huge amount to offer as physicists for finding the NHS net zero gain. So yeah, great to be here.
Thank you all. So, and we're very happy to have you all here. So we'll structure this, we'll have 3 talks in turn from each of our speakers, and then we'll wrap it together with a discussion and ideas to take things forward and really start to make big improvements and practical changes. So Manraj, when you're ready.
Great, thank you so much. I'll now enter the void of tech and try and share my screen. Perfect. So hopefully you can see my slides. I've lost all of you, so just shout if for any reason you can't see the slides or they're not moving or you can't hear me. I'll take it as a yes for now. Brilliant. So thanks so much. So I'm going to sort of give you a bit of a whistle-stop tour on how we can move towards delivering a net zero national health service. And I guess what I'd like to do is highlight why this is such an important issue. And I think Jerry already mentioned it, that it should be part and parcel of everything we do. What we're doing as a Green NHS and what we've achieved since our sort of inception, but really focus in on those actions and the opportunities that lie within some of the work that we're doing at a national level, but more importantly, on the ground where you all work. So I guess the why, and most of you probably know much of this, but we know that the climate emergency is a health emergency, and it is going to disrupt the way that we can deliver care and affect our patients and all the work we've done over the many years of delivering a health service. We're starting to see those impacts now. So we know that heat waves, you only have to look at the sun we're gone, are on the rise. Air pollution is now the single greatest environmental threat to human health in the UK, causing 1 in 20 deaths. And sadly, it's going to really undermine those social determinants of health. So there's wider things that impact the health of our patients and our population. And much like COVID, unfortunately, it's going to disproportionately affect those most vulnerable and disadvantaged in our communities, and hence drive those inequalities even further. So there is real sort of synergy with all of the things that we're trying to achieve as a health service. But it's not all doom and gloom, I guess, and I also take a sort of positive stance in terms of it being part of us being part of that sort of solution. We do have a responsibility as a health service, so we are one of the biggest popular sort of employers within the UK, so 1.4 million staff. And I guess if each one of us did something, then we could have quite a marked impact. We do contribute to the problem. We are contributing about 5% of UK emissions are from the NHS, but there is an opportunity there. So tackling climate change would allow us to leverage some of the health, environmental, social, and some of those financial benefits that come with that action. And we know that this action is good for health. So they are clear evidence there that we can improve and save lives if we improve air quality, physical activity, and healthier diets. So there's a sort of a win-win situation, really. I guess the NHS has taken that on board and really started to take this forward. And we became the first health service in October 2020 to vow to be net zero. And this was done through this landmark report. If you haven't read it, it's a bit of nighttime reading for you all. It's how we can get there. And really in that report, we've highlighted two ambitious, but hopefully feasible targets for net zero for those emissions that we control directly by 2040, and some interim targets there, which are closely coming up. And then net zero for those that we can influence. So those are sort of our wider supply chain by 2045. And that sort of was 2 years ago, but none of this work started then. It's been ongoing for some time. So some of you may be familiar with the Sustainable Development Unit, which was set up by the government really in response to the Climate Change Act in 2008. And then jump forward to 2019, and we have some ambitions within the NHS long-term plan to really push this agenda forward and make some commitments to reducing our environmental impact. And that's really where the Green NHS programme came in, sort of launched in January 2020. We have the first Chief Sustainability Officer, Nick Watts, who I was a fellow for last year, and Ellie was involved in quite a bit of the work we were doing there. And then this delivering a report, and really now we are moving this trajectory forward. We work very closely with NHS England. We have to report to the board and show that we are heading towards a greener NHS. So the strategy itself, I'll just touch on that to some degree in terms of what we're doing. It lays out the carbon footprint, so where we are now, projections if we are to do something, and then really looks across how we get there. What are those key interventions that we need to progress this at a national level, mostly driven by individuals like yourselves on the ground looking at things. So the carbon footprint itself is divided into these scopes, and you don't need to get bogged down by this, but really it is those emissions that we control directly, so our anesthetic gases, our facilities, and then scope 2, which is indirect emissions, mostly from the energy that we purchase, and scope 3, which is everything else that we can have some control over. So that is that supply chain, 80,000 strong, 60% of our carbon footprint. And what we're looking at within the NHS targets is to encompass all those scopes, as well as capturing sort of travel from patients and visitors. And that really is a sort of all-encompassing aim for us. And this really highlights where those carbon hotspots are. And I guess as medical physicists out there, you think, where do we fit in? And I think there's a huge amount that you can do contributing to reducing these emissions. And I've just highlighted a few here. So, you know, the way we run our buildings, energy efficiency, and the equipment we use in there, huge MRI scanners, PET scanners, etc. The staff travel, patient travel, radiotherapy, and I'm sure Jerry will touch on some of the work that they're doing there. And then equipment, which are key parts of this. And on the side there, you can see that it crosses across all sectors. So whether you work in acute care or primary care or community services, there is some bubble of carbon that you can control or change. How we go about doing our work from a national perspective is really looking at those interventions and those hotspots from direct interventions in our estates and our travel and transport, but also indirect interventions. So looking at that research and innovation, how can we have this as a running thread? And models of care, which is really where I sit in terms of my portfolio of work, and looking at how we can transition this into not just being estates and travel and transport, but really how we design and deliver care and change care for our patients in a way that's good for the planet and good for them. So I thought I'd highlight some of those key points or things that we're celebrating. Now we've hit our 2-year mark, and really it's to say that there is support from above. You know, our chief executive, we were quite a big feature in COP26, and this is a very apt time seeing as we go into COP27 as of today. And that we're on track. You know, in our first year, we were able to reduce our emissions enough to power 1.1 million homes if kilotons of CO2 equivalents doesn't mean much to you. And I think a really big lever, as Katrina mentioned, is having the ability to say that this is now part and parcel of legislature. It is enshrined in our health and care bill that we need to take this on board and move it forward. So some highlights that hopefully give you all a bit of an idea of what's going on and maybe some ideas as to what you could do. I'm going to focus in on a couple that I think are important and some examples that may ring true. So one is our estates of facilities, 15% of our carbon footprint. And there's a lot of scope within there to start to look at investing in our buildings. We've had the public sector decarbonisation scheme launched and quite a lot of capital investment coming in through that. Looking at how we can go towards more circular economy principles, engaging our supply chain, as I said. And there's a brilliant case study, if you go on the Green NHS website, from Milton Keynes, who've looked at installing a huge amount and have done in solar panels and are powering quite a lot of their energy from that. Gives them energy security in the current climate, but also allows them to have a renewable source for a lot of those energy intensive areas, such as MRI scanners. And on the right, there's an image of someone working within those scanners. A huge amount is happening, as I said, in the supply chain. So we've got a commitment that by 2030, we won't purchase from suppliers that aren't aligned with our ambition. Supply chain makes 60% of our carbon footprint. And we've laid this out in a clear roadmap. And the aim is really to take our suppliers with us, to have them have decarbonisation reduction plans and start to move together on this. And I think there's a role for those working in trusts to start to engage with suppliers on this issue and start to move this forward. Most of you will be familiar with the sustainable procurement good practice around really thinking about our waste hierarchy. So looking at reduction as the key thing, and then working through how can we start to reuse certain equipment, reprocessing, and then really moving down to recycling being the sort of bottom part of that waste hierarchy. Travel and transport, as I said, 14% of our carbon footprint. And again, lots to be said there. We've got our first net zero ambulance out, lots of e-bike couriers now being used to transport things. And this really shows that you can change practices within your own organizations and your own departments if you just sort of think a bit more innovatively, I guess, in some instances. Medicines is a huge amount that we think those at the front line can start to influence. 5% from our anesthetic gases and inhalers. And you may not have a direct influence on this, but this is just to show that, for example, with our inhalers work, we now have an incentive within primary care to allow that transition to low carbon propellant inhalers. And anesthetic gases, we're really starting to move away from desflurane, a potent anesthetic gas with a high global warming potential. And 20% of our medicines footprint comes from that wider piece. If you take away the 5% from our supply chain, and there is medicines and chemicals in that. So, you know, if you think about the contrasts and other elements that you use in your day-to-day work. Just focus in on models of care, and this is really around how we change the way we design and deliver care, looking upstream, keeping people healthy. We know that all care components, all elements of how we deliver care has carbon associated to it, and if it's more burdensome or more intense, then it's likely to have a higher carbon footprint. So if we were to reduce that demand, reduce that burden of disease and work on prevention, we would sort of start to reduce that as we go through patient's journey. Obviously, we're going to need to deliver care. So for those that do need care, we need to ensure it's at the right time, right place. And when we start to thinking through delivering that care, it's really about delivering that care in a low carbon way? Are they low carbon alternatives? Can we think about sustainable resource use within that? And this is just to show that we're starting to think about this from a pathway perspective as patients move through things. There's a huge amount of investment coming in now, and this being acknowledged as a real area for research and innovation. We've got our small business research initiative open at the moment, looking at how we can move towards reducing emissions in care miles, surgical pathways, and that low carbon decision making, and huge amount going into NIHR funding as well. I guess a key element for those of you starting off on this journey is to start to leverage and link up with elements that are going on and getting leadership on board. So as of now, we have green plans for all trusts and ICBs in place. There should be board level leads out there in the system for you to get in touch with, and I guess support them in delivering their green plans, but also find opportunities for yourselves to get involved in your departments and your areas of work. And to show that this is partly, driven by data to begin with that carbon footprint, but also we're starting to really monitor where we're going. And there's a Green NHS dashboard where you can see carbon footprints related to certain elements that I've touched on already. And I guess what can you do if it all seems a bit daunting, and it often does, is to pick an area. And we know that there is momentum in the system and people want to do something. 9 in 10 staff want to see us tackle this. And we're starting to see certain, I guess, clinical tribes or the sort of wider workforce within the NHS really take this forward from a different angle. And it'd be great to see sort of medical physicists follow in suit and become part of this photography exhibition that was going around last year. I guess other elements you can do is really train yourself up. There's some free e-learning that's out there, that's available. But also it's to sort of join communities, join networks, have webinars such as this, and really start to create a space for sharing ideas and networking and collaborating across sectors. And I'm sure Ellie will touch on the fellowship scheme that she was part of last year, and it's really an opportunity to show that we're creating space for such valuable work. So I've covered quite a lot there, and I haven't given you the most tangible examples, and I hope Jerry will do that, but it is around starting to think about how you can start to change things in your day-to-day, having these conversations, starting to lead by example, and really start to collaborate across this. And I guess we need everybody to come on board to make this, to hit our targets, but also to make this sort of better for our patients and within our environmental boundary as such. So I'll stop there, and I'm happy to take any questions sort of now or later, whenever sort of suits you. Thank you.
Thank you so much, Manraj. It's really great to have you here today. One of the things that isn't in the Greener NHS document is any specific mention of medical physics. It's really great to have people like you that are coming and interfacing and sow the seeds that we can take forward within this discipline and with clinical engineers as well. So Jerry, and I'll just say the Q&A box is live. If anyone has any questions, we can take those all at the end, or if there are any burning questions, we can take them during the talks. And without further ado, I'll pass on to Jerry Lowe.
Thank you very much, Manraj. That was really interesting to hear, and it's very good to have that introduction to Greener NHS. So what I'd like to do in the next 10 minutes or so is present the kind of bottom-up views. So we have that presentation of the top-down, as it were, the Greener NHS, which is very much embedded in our management structure now. But I'm just a clinical scientist in a department, so with a little bit of experience of what does and doesn't work at departmental level, which is what I'd like to kind of talk about in the next 10 minutes, if that's all right. I'm very happy to answer questions as and when. It's really interesting to hear about Greener NHS, and I think that's something of which we should be really proud, because to emphasize, this is the first healthcare system, I think globally, someone correct me if I'm wrong, that has put in place anything like this magnitude of ambition, and the net zero targets are better than the UK Climate Change Act. They're better than pretty much anything else in the world, and we should be really proud and get behind that initiative. But one thing I've found fairly consistently is we're still at a stage of raising awareness in the ordinary NHS departments. So in the last half dozen or so meetings that I've been to on technical issues, nothing to do with sustainability, I've just asked for a show of hands in the audience, as for face-to-face meetings these days, of course, who's even heard that greener NHS is a thing. And consistently, I get about 10%, maybe 15% on a good day, maybe 5% of people will put their hands up. It's not yet bread and butter around the NHS staff community that this is happening, let alone the magnitude of the greener NHS ambitions. And we face, of course, a system which is really sometimes very stressed. We've just had a pandemic. We know all the stresses the NHS is under and which we as individuals are under. And yet there is this in Greener NHS initiative happening in the middle of it and coming out of it. I think raising the awareness of ordinary staff is something that I've tried to do, and my group in hospital here has tried to do. We've given talks to staff meetings. We've had a little display put up in our or near to our canteen. And I think that's key, because if this is going to work, if we're going to hit these targets, then it's going to require the input, as Margaret has said, of every member of staff. And I don't think we're there yet. I don't think most staff, even in a technical department like a physics department is, I don't think we're there that everyone is aware of what we're trying to do, where we're trying to go. So that's probably the first thing I'd say. So it's really important to get the message out there in our departments that that this is what we're trying to do and this is what we need to do. And we've done surveys, we've surveyed staff, and I know other departments have surveyed staff within the physics departments and wider, and the results are exactly the same as Manraj just said. About 90% or so will want to do something, consider it important. But also what our surveys have said is fairly consistently about 15% really know what to do, come to work knowing what changes can be made to make things more sustainable and to improve on the carbon footprint. So there's a big gap there between people who want to do something and people who know what to do. So again, it's really at the level of raising awareness. Now, what have we done? So one of the things that we've done is try and set up a kind of, we call it a green ambassador scheme. So the idea is that within each department, within each group of people, probably smaller than department level, there is someone who has the green initiative on their radar and brings it to the conversation, so that when we're talking about what we're going to do, how we're going to do things, what IT we're going to buy, what protocol, how we're going to do what we do, there is somebody who specifically will make sure that the green agenda is part of the conversation. Now that works really well, and we've had, I mean, when we set it up in radiotherapy physics, where I'm working from, it's not me, it's one of my colleagues, the Green Ambassador, and within a few weeks, the quality of our waste segregation improved, for example, and the amount of IT equipment left on overnight, that went down. So changes get made. The problem we're having is how to roll that out into a hospital-wide or a trust-wide system. So we have the people who are interested in the subject anyway, and they're doing a fantastic job. But how to get from there into something where every place in the hospital, every ward and every department has its green ambassador, that's where we're at, and that's where we're struggling. I think not because people don't want to do it, but it's somehow we've got to get it in onto the radar that even with everything else that we have to cope with, infection control, all the stuff that goes on, all the stuff that we need to do, all the mandatory training that we need to do, we need to get sustainability in there as well. And I think that's where we are as a hospital now, starting off, but not yet fully covering the whole institution. So I think that's quite key. There's a quite key thing to do. And in terms of what we've achieved, well, I've mentioned it already, waste segregation. So there is a huge overlap between environmental sustainability, and financial sustainability. So when we segregate waste wrongly, we get charged for it. So it actually makes sense. And there's the total management buy-in at my institution. Forget your waste segregation correct. Put the right things into the right bins. It's recycling works, but also we'll be charged less for it. So that's one big thing that we've concentrated on. We're having another initiative of that now, just to make sure that recycling facilities are available throughout the departments. And just go back when they're not being used correctly and politely and nicely say, well, why does this happen? It doesn't take any longer just to pop it in the right bin rather than just the wrong bin. And then the other thing I mentioned already is power use. And of course, that's very dependent on the IT. And there's a question raised about age of radiology equipment, whether it has an effect on the amounts. And what we found I went around with a little power meter, the thing you can buy for £20 or something, plug into a ring mains, and then plug your equipment into that. And what I found is that there's a huge difference between the age of equipment, between how much standby power it takes. So the PC on my desk here will sleep overnight down to less than a watt. But there's also equipment we have where we have screens that will blank, but the backlight stays on, and they're taking 80 to 100 watts all the time if they're left in that condition. So in my department, when we started, we have best part of a kilowatt of screens left on overnight and at weekends, just doing nothing. And then of course this was summer and the air conditioning was having to chuck that heat out of the department. So okay, that's a heat pump, so that's probably not very much, but there's a kilowatt of energy going on that we could easily save just by getting people to flip the buttons on their screens before they leave. So there are some very easy wins which we've done and which I'd recommend. And again, green ambassadors can just keep that on people's radar, because if it's not on people's radar, then it gets forgotten about with everything else, with the best one in the world. So I think that's a really key thing to do. Where I think we are and where I think we are struggling is to know how to make real impact beyond the easy things, and that will be something that we'll need to address in the next couple of years, I think, and hopefully with the support of Greener NHS and other similar organizations, because obviously everything is done for a reason. It's not always a good one, but it is done for a reason. And for example, we're working in our trust on the use of reusable PPE. So we obviously have these things which you chuck away after 4 hours or whatever it is. And there's a huge environment, both carbon and pollution hit just down to these masks and the aprons, obviously, that you wear for a clinical episode. Now, there are reusable alternatives, and we're looking at one company called Revolution Zero, which does this. Now, our IPC group is very supportive of us. They see the problem, they get the problem, they see that this needs to change. But there's a big road between seeing the solution and actually implementing it, making a business case, making it happen. And there's a lot of talking and a lot of emails, a lot of meetings that just need to go on. So it's kind of frustrating in a way, because it's so little changes, and you know the speed with which it has to change. But I think I'd want to say that we need to get in and start these discussions, because people are supportive, and and the feedback that I get is always, we want to do this, we don't know how to solve these problems with introducing a more sustainable solution, can you help? So I think there's a lot to be said for starting where we are, and be prepared for the fact that some roads are very long roads, and there will be a lot of talking, there will be a lot of meetings. There are very few people who say this is a waste of time. Most people see the point, but it's necessary to accept that major changes take a long time to achieve. One of the things that we found is that there are kind of informal groups forming around specific disciplines. So my one is brachytherapy, and that, for those of you who aren't radiotherapy people, is just where we're using radionuclides inserted directly into a tumor to treat that tumor by radiotherapy. If the tumor is accessible, and if you can do that, it's a great way to, and a very simple way, to provide a very effective treatment. Obviously, it's surgical. That brings us to theatres, and there is and there are meetings between of various different groups, as we all know. So there's a brachytherapy meeting that exists in the UK, and there's also some work I'm also involved with PET, radionuclide imaging. And within each of these, there are groups of people who are interested in improving sustainability of what we do. And this tends to get coordinated in medical physics by the IPEM Environmental Sustainability Group. I would recommend that if you want to make a positive change, get in touch with the IPEM group, because the chances are there's already a group of like-minded staff up and down the country who are trying to see what can be changed. And it's very worthwhile pooling efforts here and working towards a model of best practice. So whatever you do, get in touch, and we can, and your input will be very appreciated, and we can also share what's already been achieved in the different areas. The other group that's ongoing at the moment from the IPEM sustainability group is looking at the footprinting of radiotherapy. So there is some literature in terms of carbon footprinting of a specific procedure. Not a lot in medical physics yet. The renal people have got quite a lot out there, the surgical people have got quite a lot out there, but in terms of medical physics, there's not a great literature. There's some on CT and MR, there's not a great literature in radiotherapy and on PET in terms of what is the carbon footprint of our procedure, because until you measure it, of course, you can't reduce it. You don't know where the hotspots are, you don't know what you can change, you don't know what control, you don't know whether what you can do will have a big impact or not. And of course, the last thing we want to do is spend a lot of time putting a lot of effort into something that's going to produce relatively little return. So in terms of footprinting work, there is a group now looking at the carbon footprints of delivering external beam radiotherapy. We're also probably going to look at that in terms of brachytherapy and of molecular imaging. So the specific projects which hopefully will be reporting in the next year, 2 years, something of that time scale. Again, get in touch if you're interested in helping with that or want to contribute. And as part of that, there's also some work looking at things like the power use of Linacs in quite some detail, because they're complicated bits of equipment, but there is opportunities there to optimize what we do. So there's some work there as well. The other thing that's worth looking at is through all of this is measuring your impact. And I would say that if you're going to do something, it's really good to have some kind of measure of how well what you do, how well your intervention works, and what kind of carbon gain you get from it. We discovered this the hard way, because being just a group of clinical scientists working in a department, we didn't want to hang around measuring things. We just wanted to change our practice for the better, which is fair enough. But now we're finding that we're being asked by potential funding bodies for how good our intervention is, what we're doing, how well it works. And I'm realizing after the event, in a way, that it is very good to get some measure if you make a change of what actually happens in practice. How good is it? Has it worked? What has worked and what hasn't worked? So bear that in mind if you're going to start something in your department. That time spent making measurements is probably time well spent in the long term. The last point I want to make is to do with funding. So as a department, we've found very quickly that you hit the point at which you run out of spare time. I think the concept of spare time in the NHS is a bit, no one's got any. And very quickly you find that although there's a lot of goodwill in terms of staff, and people will do a lot for you if you say you want to make a specific intervention which will improve sustainability of your department, very, very quickly you find that there just isn't time to do it. And for that reason, we're starting to look at having a library of projects that we can pull off the shelf when funding becomes available. And there are various funding streams, both from around the NHS and external charitable funding streams. And I think that there's a lot of optimism that we will be able to get funding for specific things like training in awareness of sustainability, specific interventions, specific projects, but they all come with very tight deadlines, as we know. And so one of the things we're now trying to do is have this library of projects that we want to fund, that maybe when the project leader is on annual leave and something comes along, one of us can come and take that and cast it in the form of a proposal for a funding by a specific funding body. I think that hopefully will prove valuable in the future, although I have to say as a caveat, we've not yet managed to be successful in that way. There's a question as to what the biggest challenge or obstacle is. And I would probably say it is that combination of a lack of staff time together with the fact that that it's necessary to comply with so much in the NHS. So to take another example, packaging for radioactive materials, which is something else we're looking at. They're often very heavily packaged, but there's a reason for that. They have to be, they're regulated, they have to be type A, they have to comply. And it really is around trying to work with other bodies to try and see if it's possible to meet the necessary regulations in a more sustainable way. Okay, well, I think that's all I want to say now. Very happy to take questions later on, and thank you for listening.
Thanks so much, Jerry, and thank you for the questions that have been submitted so far. I'll hand over to Ellie, and then we'll take all the questions together at the end. Ellie, over to you.
Oh, thanks. So yeah, thanks both of you. They were great intros, and I was like slowly molding how I was going to do this section, listening to you both. So I'm actually in quite a good position to talk about the in-between you two. So obviously we've got kind of the very top level of you, and we've got what you can do on the ground in the department. So I'll talk a little bit about my journey in the environmental space as a healthcare scientist, and then kind of how we can have huge impact on the NHS net zero agenda. So I started, as I think most people in the environmental, who've got an inkling towards the environmental space, cups. I was desperate to get rid of disposable cups in my department. And I know there's a few people from my department listening today, and they will probably confirm that I'm quite annoying about it. But start there, start small, but it did make progress, and it started discussions. And that is one of the key things. If you're looking for anything to do, start talking about it, as Jerry kind of spoke about the Green Ambassadors. And then you go on to PCs, and then waste and all those things. And then you reach a point where you're like, what can I do to have more impact? So I was quite fortunate. I was in a good position to take a secondment a few years ago. And I went to the Department of Health and Social Care. And it was to be on the PPE programme, which is hated, I think, from a lot of places around the world. But I was going to join this team called the Innovation and Sustainability Team for PPE. And it was going to be a small group targeted with trying to improve the quality of PPE and also the environmental impact, because even early on in the pandemic, it was noted that this was an absolute environmental disaster. The amount of single-use plastic that was being thrown away. It was a disaster from an environmental point of view, but it was actually, we were having a bit of a crisis from a waste management point of view. It did come out, so I can say it, but there were days where hospitals almost shut down because they could not deal with the amount of waste that needed disposing of. The waste centres could not keep up with it. So it became a real problem for everybody. No one wanted a hospital closing. And also there was issues with the environment. So I joined this team thinking that I was, junior member going into the Department of Health for the first time. Oh, they won't give me anything too serious to do. Oh no, can you write the sustainability strategy, please, for our programme of work? What? That's not me. I've never done this as a job. But this is where you learn a superpower you have as a scientist. You just go learn about it. Literally, you know how to read sources, you know how to interpret them, you can look at legislation. Particularly as clinical scientists, our job is literally reading legislation all the time and interpreting it. So, and you can apply that to different areas all the time. So I would say I'm now fairly, or at least was a fairly good expert in waste management, health waste management, and also how you wash things, health laundry. But all it is you learn and you can apply it. And so, as you can imagine, this job was a massive learning curve. However, the biggest, I'd say probably the biggest thing I learned in that job is that we don't have to always phrase things as an environmental benefit. We can phrase it as a financial benefit and an efficiency benefit. And if you're ever talking to someone about business cases, highlight those. And I would always take that through whatever I've done. But anyway, so I did that for 9 months, and those PPE masks that Jerry's talking about, I kind of did a lot of the technical assurance of those. Again, I'm a physicist, I'm not a clinical engineer, but it's applying legislation, looking at test results, you can work it out. And actually you'll find yourself quite often the expert in the room, even though it's not your expertise at all. And it's learning to own that, and just, as long as something positive comes out of it, just run with it. Then I went on to a fellowship, the Faculty of Medical Leadership Management's Clinical Scientist Fellowship, with the Office of Chief Scientific Officer, where I met Manraj. And I was on the scientific side. However, you very quickly, when you enter this world, find your kindred spirits around, and you have loads of multidisciplinary events. And through those, I found a whole team of people who are interested in sustainability. And why I'm talking about this in being the middle ground is, in that group, as a multidisciplinary set of clinicians, you can start lobbying. And this is a power I think we often forget as scientists and clinicians on the ground, is you actually have a real political voice. And the way you can start lobbying is writing publications and getting the publications heard in the right places, and speaking out at different groups. Here we're in our community, but this is the start. We build enough groundswell that we can take it forward. But with this multidisciplinary group, we're writing a paper on professional standards and how they don't actually incorporate sustainability in them, and that they should if we have this legal ambition to get the net zero, but we're not training any of our staff to do it. As a scientist, I'm there talking about good scientific practice, and then we have clinicians, and we're writing all of these documents, and we're going to write this paper, and we're going to send it to BMJ Leader, and we're going to lobby all of the professional bodies. Now, why this matters is because if we can get that in education and training and in professional competency standard for qualified professionals, all of a sudden you have to start doing CPD, which is acting towards net zero ambitions. And all of a sudden, you've made it everyone's problem in the team. It's not just a nice to have, it is part of everyone's job to contribute towards net zero. And anyone here could do that. We could write a paper as physicists and send it off to IPEM, to IOP, and start getting that in. And then it will go on people's agenda, and you will start seeing more change within our professional community. The other thing that we're doing that's kind of that middle ground is we're trying to work with some of our suppliers, particularly linac manufacturers, for example, and get them to work with us on doing life cycle analysis. Now, okay, that will benefit us on the ground, going, okay, we can look at your 2 analysis and decide which one we think has a higher carbon footprint, and potentially include that in our procurement process. However, the bigger step is, once they've got those 2, that you've got a life cycle analysis of the 2 main providers, heaven knows they are going to start competing with each other to bring it down. Because especially now it's in a white paper, you're meant to include 10% of the procurement assessment on sustainability. So once you've made it a feature they have to consider, we will start seeing those things coming down. And at that point, we don't have to do all that pushing on the ground. They will do it themselves just because they want to sell us linacs. And you can, as physicists, you can do that across all of your suppliers. Use market competition against them. If it makes competition, they will do it. So, and particularly with procurement, make sure you enforce about that 10% weighting, and tell them about the commitment to not engage with suppliers who aren't signed up in the next few years. Because I think, although we're working through it with NHS supply chain, I know we do a lot of ad hoc stuff in medical physics. So it'd be good if we can take it forward as individuals with our particular suppliers as well. So I'm kind of doing a bit of just a run through of all the middly kind of stuff we can do. And what I'm trying to say is, if I can do it, and I'm 5 years qualified, I think, ish, and I'm there trying to lobby out of the system, anyone can do it. And I think sometimes physicists and scientists, we kind of need to expand our horizon of what it is we're trying to change. We can do it in our departments, but we can actually change things at political levels and at professional body levels, which will have a far larger impact. And so if we can try and direct some of our energies in those directions, we can have maximum impact for our time. And I was just going to, kind of say one of the things that happened to me when I got really involved in sustainability, and I think it happens to quite a few people, you can get overwhelmed, really overwhelmed by the state of the world, and you can feel quite powerless. And there was one time I walked into a supermarket and I really wanted salad for dinner, but I got so stressed by the amount of plastic, I walked out and instead found whatever I could eat at home, which is probably a good thing anyway, but it was probably baked beans, which is my standard. And that can be a really paralyzing moment. And I'd say if you get to that stage, the real way out of it is finding positive actions you can do. So if it all seems too much, it's too overwhelming, just try something small, get involved with a group of people. We're really friendly in the IPEM sustainability group, and you can just have those conversations about how we can improve things. And once you start seeing things improving and that you are having an effect, you will probably start feeling a bit better. And it's all just a little start going forward. Yeah, that's kind of where I wanted to finish.
Brilliant, thank you, Ellie. I think that's a really good point about the role that scientists can bring to this. You've got the quantitative skills, you've got the research skills. It's really about bringing that together and communicating out to your peer group and then influencing from there. So we've got a number of questions come in. I'll read them out, and then any of you that would like to take them can do. So first of all, do you think the age of the radiology equipment has any effect on the amount of carbon emission?
Scientist in me wants to say I need to measure it. I don't know, Jerry, you got any?
Well, I guess there's a balance there. I mean, as I've always said, newer IT equipment is likely to be much more energy efficient. On the other hand, you've also got to consider the embedded carbon in the equipment. So just from this consideration alone, there will be a sweet spot in which you replace it. Fairly hard to measure, but typically the embedded carbon in a scanner, for example, is huge. So that's quite a problem. Maybe we need to look at that more in the future. I'm not aware of a literature on that specifically for medical imaging. We probably should look at it.
Maybe this is firstly an opportunity to get the manufacturers to bounce off each other and innovate downwards, I guess, in carbon, and also for IPEM to work with and other organizations to work with people like AXA and the manufacturers directly. Okay, next question. Do you have any thoughts on the use of single-use plastics in waste disposal operations? So as an example, putting clinical and other waste in disposable plastic bags into fairly substantial plastic bin containers. It's a clear need to ensure the safety of staff handling waste, but maybe there's a better way.
There is, and Maraj, you might know about this as well. There is a big movement in NHS England. There's some guys that are really trying to reduce the impact of waste from the NHS. Their big problem is the regulations around waste management for health, particularly with disposal. which is where possible, reusable makes your life easier, which I know Jerry's probably not going to smile at that. Trying to get reusable in is hard as well. But all the while we're waiting for those regulations to be updated, it's very hard to change that. There are some companies you can look into. RecoMed do recycling of clinical waste, and I think there's a big waiting list because so many hospitals want them. But basically it all comes down to a license to process clinical waste, which makes things complicated. And kind of back to what Mamraj said about your CIA goggles, what you can control, what you can influence, and what you have to accept, and challenge your energy at those first two. But also, if you're feeling nervous about it, go find out what is happening in those spheres that you have to accept, because people are trying to make it better.
Can I just add, quick win we've had in theatres, because we do brachytherapy involves theatres. When I started, there was one orange bag, everything went in there. Now it's easy hit to get someone to put a recycling bag next to it. Then yes, you have to segregate, but theatre staff are all completely aware of whether they're handling sterile, non-sterile, contaminated. They'll very happily segregate it for you.
Yeah, I was just going to add to that, Jerry. It is about understanding that system, isn't it? Sort of thinking about the multiple bits that go towards it. So nitrous oxide work we're doing, for example, finding out that actually a huge amount is just wasted. So that, waste segregation is a big part of managing the recycling at the bottom end, and the same with the equipment. You may not want to change all of your really intensive embedded carbon equipment, but you may want to see how you could make it more efficient, or switching it off if that's feasible. But I think there are some smaller wins in those scenarios, and just knowing a bit more about it from a research perspective.
And a quick follow on from that question, sort of in the same vein, someone says their trust has an off-site recycling policy, so everything goes in one bin and is then separated by the provider. Is this easier, or is it a bit wish cycling, which is a good phrase, with too much chance of contamination?
I think, again, without knowing the ins and outs of those systems and what happens to that, but maybe I'll let Ellie or Jerry come in.
Jerry, so I think every trust has its own, at the moment, contract around waste. So it would really depend on who the contract is with.
Get in touch with your states.
Yeah. What we found, again, in my centre, is that there's confusion between as to what goes in which bin, because it can be different where you work from where you live, obviously different contractors. So really, we made a little video, which you can, it's about 5 minutes long. There's a QR code, we stick it above the bins, you can scan that, and it'll show you what goes in which bin at work. If you've got a one bin for everything, then obviously that's less applicable, but people need to know that.
I'd also think if it didn't work, I don't know, it'd be interesting if it didn't work, because there is huge financial variation in the type of waste, like because you pay basically a huge amount for if it's clinical waste, and it's like barely nothing if it's recyclables. So you'll find your waste managers really trying to make sure you put stuff in the recycling bin, because there's real financial implications. So it would be really interesting. The contract that there is for that all in one, unless it's all in one domestic and recycling with separate clinical, I think is the only way that could possibly work.
Seems like there's a lot of shared learning to be done on how best to make financial cases to make your points across, which I suppose is a practical point, a little bit bleak. So on a completely different tack, this question refers to Miles Allen, Professor of Geosystem Science from University of Oxford, talking on Sunday about the idea of carbon capture and storage. Carbon dioxide is literally scrubbed out of exhaust gases, or even from the atmosphere itself, and stored safely back underground. What do you think would be IPEM's opinion on that idea as an organisation? So I think that's direct carbon capture.
I was leaving that to you, Jerry.
Leave the IPEM. I'm not sure what IPEM's opinion. I think, personally, I think it's sadly necessary to remove carbon from the atmosphere. Now we've got to this stage. That's my personal view. That's not an IPEM view. But I think what is fairly uncontroversial is that it's better not to emit it in the first place.
Yeah, I think it's difficult to have an IPEM view because all of the views that we do have on things like this come from our members. So for a single person to come on a webinar and speak to it is a big ask. But I will put a link on to the environmental sustainability pages in the group in particular, which is a great lobby to have these kinds of discussions. Slightly more light-hearted, Ellie, are you only concerned about disposable plastic cups or the paper ones too?
I wouldn't like either. It's the easy answer. Yeah, I mean, you've got your order of like the sustainability order of things, and it's like reduce, reuse, recycle, repurpose. So try to use fewer, use reusable if possible, then you use recyclable if that's not an option. And then, yeah, the whole idea about repurposing if it cannot be recycled, and try and apply that little down everything you do. There are obviously times where we still need some single use, and it's really hard when you get into discussions about the energy consumption from cleaning, but you know, a little rinse your tea mug better needs to clean anyway, it's fine.
Well, I think we've pretty much run the full gamut from Linux to paper cups. So towards the Linux end of the spectrum, I guess, how do you go about measuring your carbon output in order to determine any gains from making changes? This is really it's one for all of you from Greener NHS and around your experiences, and also you two, what you've been doing in the group.
I think from my perspective, what we've been doing at Guys really follows Catherine's work at Swansea. Her HSST project is on measuring the power. So we're starting with power consumption of Linux because it's something measurable. And we're using a Fluke power meter to measure both standing power and different treatments. And we're starting with that. And then you can find conversion factors. And it is still an academic debate about different conversion factors, because obviously it will depend on what your energy source is and things like that. So there's a lot of assumptions through it. But yeah, we're starting with power consumption of the Linux. Ideally, we'd also look at the imaging, and we're looking at SF6 use, and also patient transport. And so let's give you a little preview. Patient transport tends to blow most of it out of the water. For those of you in radiotherapy or in other areas, minimizing the number of times patients have to come to site is your biggest solution for reducing the impact of the pathway.
And obviously good for the patients as well. I'm sure they don't want to come repeatedly. I think there's a couple of different ways to measure it. That you can do a paper. There's an academic discipline emerging, and I'd recommend this Centre for Sustainable Healthcare course in carbon footprinting, because that shows you how, or the techniques used. In particular, it's possible to get almost any figure depending on where you put your boundaries. So it's quite important to do something that fits in with the methodology used already in the literature if it's going to make a useful comparison. And that course will tell you where the boundaries are, or just look at the existing literature. It can also be done less formally. So, for example, we just look at the number of screens that are left on overnight, and you can feel the back of them. You can feel whether it's 100 watts or 1 watt very easily with your hand. Sometimes you don't need to quantify the carbon. You just need to quantify the item, in this case, electricity, and it's a surrogate for it.
Yeah, I mean, I'd agree. It's a complex science, and you can make it as complicated as you want, and there's different ways of doing it. I guess you'd have to ask, what you're counting and why. And like Jerry said, there are certain assumptions and certain principles we know that would lead to sort of better, lower carbon options. And therefore, you probably don't need to get bogged down with the numbers to such a degree. But there are resources out there. There's also the Sustainable Healthcare Coalition that has a pathway guidance. So really taking a sort of end-to-end view of it. And I guess over time, we'll have a sort of generate these average factors that can be used across the board, so not everyone is going back to the drawing board each time and doing a really detailed life cycle analysis. And that's part and parcel of these kind of groups, is to share those hotspots. And that's a key thing. Those individual numbers, maybe the accuracy of that individual number doesn't matter so much as sort of what is its proportion alongside everything else. And you only need to do that a handful of times, but we may spend a lot of time counting and very little time doing something about all of those numbers. So I think the message is to sort of share as you learn, really. But yeah.
Sorry, I muted myself. Rookie Zoom error. So I'm just sharing now the slide with our links to the Environmental Sustainability Group and IPEM's policy, the Chief Sustainability Officer's Clinical Fellowship Scheme, which both Manraj and Ellie have mentioned today. And just while this is on the slide, if I go around, starting with Jerry at the top of my screen, if you could just give one take-home message for the audience today.
Just start doing things. Just start it in your department, raise the issue and get it talked about, and go from there. And
Ellie?
Yeah, just say that, you know, we've said it throughout, climate crisis is a health crisis, and putting this part of our job should be as important as when we're thinking about patient safety and efficiencies and financial savings. It's as part of it as anything else. And
Manraj, last but not least.
Thanks. I guess what it's been brilliant to hear everything that's going on. I guess what I'd say is that the only way we move forward is with all of this amazing work going on at I guess the bottom up, as Jerry said it, but we are here to support and keen to create levers and enablers in space for that. So definitely complex system changing, and we all need to work together on it.
Brilliant. I have to say this has been what can be quite a bleak topic. This has actually been a really positive and uplifting webinar. So thank you to our speakers for their time and their passion on the subject. And thank you to our audience for joining us today. And with that, I'll wrap up. We will be sharing a recording of this webinar. And if anyone has any questions, if you direct them to the IPEM office, we'll pass them on and get answers back to you. Thank you very much.
Thank you.
Thanks for having us.